All right, good morning. This is Senate Health and Welfare. It's Friday, April 5th. And we're looking at H 847 again on the peer support provider recovery support, peer support recovery specialist. And this morning we have Representative McGuire here. Thanks for being here.
Thank you.
Why don't you introduce yourself for the record and then give us your thoughts on the bill?
Absolutely, Representative Eric McGuire. Greatly appreciate the opportunity to share on behalf, and I'm going to stay pretty much focused on the recovery peer supportive piece. And the main premise behind that, I think a lot of the testimony that's been provided in the language that's already been established is very concise, and it works within the confines of what's nationally recognized, whether it's through SAMHSA and other states. So I want to stay focused on the recovery piece. Peer is a person who draws on lived experience with mental illness and or substance use disorder and recovery, bolstered by specialized training to deliver valuable support service in mental health and or substance use setting. I wanted to rephrase that more on your human services type settings. Studies demonstrate that the use of peer support specialists in a comprehensive mental health or substance disorder treatment program helps reduce client hospitalizations, improve client functioning, increase client satisfaction, alleviate depression and other symptoms, and diversify the mental health workforce. That's why 48 other states, we do have standards already established here, and Vermont have adopted peer certification programs. Peer support can divert people from emergency services and ensure patients receive a continuum of care, saving substantial costs of treatment and improving health outcomes. Research shows that peers contribute to the ability of people with mental illness and substance abuse to obtain education and employment, contributing to communities' economy rather than depending on social safety nets alone. Federal agencies such as SAMHSA and the Institute of Medicine have identified services offered through a certified peer specialist as being valuable and effective. While increasing consumer wellness, the use of peer specialists decrease costs. Data shows a clear return on investment when peers are part of the human services system. Peer support recovery promotes recovery substance use disorders by helping individuals better engage in services, manage physical and mental health conditions, build support systems, and ultimately live self-directed lives in the community. The Substance Abuse and Mental Health Services Administration, SAMHSA, recognizes peer support as an effective, evidence-based practice. And as of January 2019, over 43 states allowed Medicaid, the state program for individuals with disabilities, are low income, and for pregnant women and their children to be billed for peer supportive services. I pulled out a couple of things. I read a lot of the information. I read a lot of the studies, and I like to be informed and educate. And also it's vitally important that when things such as these are put together, that we follow the guidelines that are already been established by our organizations that oversee and supervise these things, that being SAMHSA, the National Health Institute, as well as the Institute for Medicine. Vitally important that we follow their guidelines. We should never lean on our own understanding or go outside of the box and kind of fit a personal narrative. That can become very problematic, harmful, and result in many, many unintended consequences. Some of the data has shown, according to SAMHSA, the proven benefits of peer support include reduced hospital admission rates, increased social support and social functioning, and decreased substance use and depression. A 2018 analysis showed that providers with peer services had 2.9 fewer hospitalizations per year and saved an average of $2,138 per Medicaid enrolled in Medicaid expenditures. The Veterans Administration has recognized the value of peer support specialists to serve veterans with mental health and substance use disorders. For example, a 2012 White House executive order to improve mental health access for veterans included a directive to hire additional peer support specialists. A peer support program in Pierce County, Washington, reduced involuntary hospitalizations by 32%, leading to a savings of close to $2 million in 1 year. A federally qualified health center in Denver found that using peers save $2.28 for every dollar spent. A New York-based peer support program for individuals transitioning from inpatient services back to the community, resulting in a 47.1% decrease in total behavioral health costs. Now I know there's been much discussion in regards to how the wording is for peer support recovery individuals within the language of H47. I did receive some information this week that it seems that DIVA as well as the recovery partners have come to an agreement in regards to the language, and I just want to take a second read through this language, if that's okay.
That's good, we'll go look
Can I
at it a
interrupt
little bit.
just
Go
for a
ahead.
sec? So while Representative McGuire introduced himself as a representative, he didn't introduce himself as a director of Distance House
Right.
in Rutland. So that's really why he's testifying. It's
I
not
was waiting
testifying.
to that.
Maybe that, yeah.
I didn't realize you were the director, so maybe you could share.
Yes, let me, if that's okay, I can share a little bit of that. So,
Sure.
yes, I am the director of the Rutland Dismiss House in Rutland, which is a transitional housing provider for individuals returning to the community from incarceration, or maybe in the community under some level of supervision in which they need to be implemented into a safe, stable environment to help expedite their way out of those mechanisms. I did come to Vermont back in 2010, and along with Dr. Sharon McKinsey, we implemented what was Sanctuary House and Mandela House, which was your highest level of care for individuals coming out of incarceration. It was a very, very effective model. It reduced significant costs in regards to unilateral and collateral costs upon the system. And to this day, I wish they were still around. It was a very, very effective approach to managing and working with the incarcerated population. The ladies would come on in and they would be under a treatment furlough status, which allowed them into the community 1 year before their minimum. But that's a different story for a different time. So I do have, it has been historically my career endeavor in the human services field in the state of Massachusetts, and then continuing that career endeavor up here in Vermont.
That makes sense. It's like, how does he know so much about this?
He's just interested.
Yeah, I certainly don't consider myself an expert. I'm well educated. But I believe a lot of this stuff comes to the importance of reading the literature and understanding the literature and following the data and following the models as outlined. And when those are put into practice, usually you get the outcome that you are looking for. And I'm going to sit here and say that every individual that I've interacted with, whether it's back in the days in my supervision roles or in the days of directing programs, have been successful. Well, it matters how you are gauging success. I was once asked this question, well, how many people, do you think are out there doing pretty well and this and that? And I said, no, maybe about 30%. Oh, that's kind of low. Well, wait a minute. I'm playing second base for the Boston Red Sox and I'm batting 300 over a 25-year
That's a
career.
good result.
I'm in the Hall of Fame. So again, it matters how we're gauging success. And sometimes it's just based upon, are things getting better? Is the individual getting healthier? Are they responding to the resources that are available? And then you put it in the individualized plans to address their needs to reduce their risk. Well, that's a little bit of a backstory.
So why don't you just go ahead and then we'll wrap up.
Absolutely. Recovery support services means a set of culturally competent, non-clinical, evidence-based activities provided consistent with the code of ethics for certified peer recovery support specialists and coordinated through a written individualized recovery plan of care that document a substance use disorder and reflects the need and preferences of the individual in achieving the specific individualized measurable goals specified in the plan. Recovery support services are provided in a mutual relationship by an individual with direct lived experience with a substance use disorder or by a loved one of an individual with a substance use disorder, and include a range of social and other services that facilitate recovery from substance use disorder, support health and wellness, and link individual with service providers and other support shown to improve quality of life for persons and their families in seeking recovery from substance use. Recovery support services do not include the provision of psychotherapy as defined in section 4082 of this title. I know there was much debate, for sake of argument, in regards to the wording disorder or by a loved one acquaintance. I think loved one lines up consistently with language developed in other states and also lines up with the national model for peer support certifications as outlined with SAMHSA. Loved one is a more intimate term of connection, and I believe that will keep the field from expanding too far to where any individual can step on in and be certified as a recovery coach, receive a Medicaid billing number, and be able to draw down on Medicaid. That could be very, very problematic. And I also look at my own case currently. I am in the process of completing my licensed alcohol and drug counseling certificate, which is the highest level of licensure in the drug and well, not as high as a nurse. But the point being is there are significant criterias and qualifications that I had to complete, everything from your educational pieces to having to obtain other levels of studies and then to conduct 2,000 hours under a care provider. What would stop me from saying, well, no, I'm not gonna do that 2,000 hours. I'm just gonna go and get my recovery coach certificate and popping a shingle out there and being able to draw down on Medicaid at the same rate. That could be very, very problematic. So speaking with Brendan and with other individuals, I'm gonna really say it's vitally important that the appropriate guardrails, supervision, whatever that structure looks like, is put into place. That way, those boundaries or ethics are not broken. Let's make sure this gets conducted correctly. And I believe that this language as outlined is excellent to say the least. And I hope that you folks on this committee would support this language that's put in place.
Thank you for that. And we do have it now in a new draft that we reached out to Diva and the other experts out there, including you.
No,
We're glad to have their stamp of approval. Seriously, it does help when we have someone who's out in the field doing the work and come back and say why it's critical.
absolutely. I think also that this does expand the infrastructure of care with the recovery field, which is vitally important. It does reduce significant costs, but with that, hopefully the state will recognize this expansion and make sure we're getting the appropriate resources and fiscal things to those that are doing the work on the ground.
Thank you. Can we get your testimony to Kiki and so we can
Absolutely.
webpage? That'd be great.
Absolutely. I can
It
email
is
on.
very helpful. You have a lot of data in there that will support the bills as we go forward.
Terrific.
Wonderful. Good.
I
Question?
have a question, because you can't leave here without a question.
Right.
And so I feel compelled. So,
I think it's something difficult.
it is. 48 states have already adopted similar concept, similar approach. Vermont seems to pride itself on being, out there in the front. Plus, we have, a decade or more of attention to the opioid crisis and what have you. Any thoughts on why adoption of this initiative may have lagged in the state?
I think that would be more of a question to ask, like, Diva in regards to Medicaid. I know that Medicaid billing deciphers differently in each state and how that is funded and what can be coded is more on the state to decipher how they would like to go about that. The Medicaid part of drawdown in real estate didn't start until 2019. I do not know offhand who the first state was, but there's 37 states currently now that can draw down off Medicaid for recovery coaching, and the first one began in 2019. And I probably say that was a result of the coming into the pandemic, yes.
And let me add on to that because this committee has taken testimony on this many times. And one of the barriers has always been the definition. And how do you provide for a definition within the certification process? So that, we went through a couple of bills, at least one or two, getting at this. And so the report that's come back now is really helping us take this step forward.
Mhm.
The pandemic did get in the way hugely, but it also demonstrated the need for more recovery coaches and specialists, peer support. So, and I think another piece of this, and you can maybe think about this. Recovery coaching is prevention. It's preventing people from going backwards wherever they are in their lives, whether in transitional housing, whether other housing for folks with substance use disorder. And so as prevention, it's not always been valued. We haven't valued the recovery piece as much. And we're starting to put it into that continuum of care. So I think, we're seeing it now. We keep talking about it in here, and I think that helps. And our little recovery bill that we sent over to you guys, that's another batch. So I appreciate everything you've brought to us. It's really very helpful,
Thank you.
really good.
I appreciate the time, Madam Chair. Thank you.
Good. About time we got to know who you are.
Appreciate it.
Good. Okay, any other questions? Any other? No, we're good? We're good?
Thanks.
Thanks for your
Thank
work.
you. I'll see everybody in a while.
And if you can get that to Kiki,
I
that'd be
will
awesome.
email it over immediately.
Excellent. Thank you so much. It's nice to hear from you.
I don't know, what's happening in 11?
Oh, H72.
Oh. Warren, what?
What's happening at 11? Oh, yeah. Page 72.
Eric's coming back to that. Oh,
Not on the list, but oh, yeah, it's there. Yeah. Okay, Katie. We used to take dinner down to our distance house. Now our,
the one in Burlington,
yeah,
the one on South Prospect?
Yeah.
Or, yeah.
and then now all my friends keep doing it.
He's done a great job of involving all of us.
In this?
In the county, all the reps, everyone.
Wow,
He's into fundraising, he's into.
wow, good for him.
All over. And they're all funded DOC.
Yeah, they are. And we need more there. We need the shift from treatment and post to.
We need it all. We need the full spectrum.
Okay, so thank you for being here. And we have a new draft, and theoretically, it will be the draft that we can consider for a vote. Keep your fingers crossed. How did we go through it?
Kate McGlynn, Office of Legislative Counsel, good morning. Just scroll to the top of this document. So this is the latest draft. Really, there's only one change in this draft, although I kept the highlighting from the other changes you made. And that was you had continued conversation about background checks and what the right language was. Laura Lehman from OPR sent you a memo suggesting language, and I pulled her language into the document. So if you want to just skip ahead to look at that language,
Yeah,
do that, and then I can remind you the other
and
changes.
the
that you
definition
made.
that we have in there that Eric McGuire read is the definition. that's in there.
I don't have a hard copy of
Okay.
this, which would be really helpful to compare against. That was the first time I was aware of it, but he was using the word loved one.
Love one.
And it's
Yeah.
I'm not.
close relationship, I believe.
We have, I think
I like
that
the language we have better.
Yeah,
me
our
too.
language works.
In terms of the registry checks, so the language is, the lead-in, the director has evidence satisfactory to the director that the applicant has passed registry checks and criminal history checks that may be required in role, was the language suggested by OPR. So that appears in two places. And that is the only change in this draft since the last time you looked at the bill. Just to remind you about some of the other changes that you made. There was a request to turn recovery support specialist to peer recovery support specialist, so that change is made throughout. And then you added the code of ethics for peer recovery support specialists. And you had to make a few corresponding changes to make that happen. And then you spent a bit of time looking at the definition of recovery support services. And that is where you added a cross-reference to the code of ethics, and that is also where this conversation was in terms of somebody with lived experience.
Can you show us the paragraph which we were just talking about as far as the language of loved one versus was,
I have not received any bill.
what's in the,
This is it.
Right there.
what page is it?
Read it to us, Katie.
Page
six.
Exactly where it is. It's number 10.
Okay, it's the second sentence that you're interested in. Recovery support services are provided in a mutual relationship by an individual with lived experience of either recovery from a substance use disorder or having a close relationship with an individual in recovery from a substance use disorder, and include a range of social and other services that facilitate recovery from substance use disorder, support health and wellness, and link individuals with service providers and other supports shown to improve quality of life for persons and their families in and seeking recovery from substance use.
Thank you.
And this is the one we've talked about quite a bit, and I think others have provided some input. Okay. Any questions now? How we feel about this overall with the changes that Katie has put in?
He mentioned that, he pretty much stayed within the SAMHSA. Is that loved one in that?
I'm not sure where loved one comes from. I'm not sure it's from, is it from SAMHSA? I think.
I couldn't tell you without.
Yeah.
I think that's what he said,
Yeah.
yeah,
So,
but I still like ours better.
yeah,
He likes to be there.
it's a mutual relationship, someone in recovery, so. And I think that, the OPR will be able to solve that. Okay.
He'll be devastated if we don't use one.
Oh,
He'll get over it.
yes.
It's tough.
Okay, do you want to hold this bill over, or would you like to move it forward? And I'll leave that to you if there's someone who wants to move it. I'm happy with that. If you want to hold off until Tuesday, that's also fine.
I'd like to hold till Tuesday. There's one more thing I want to look at. I'm overall impressed with the bill. I just want to do some research over the weekend.
And on which area?
On the area of who's providing testimony. Want to make sure we're covering all bases.
Okay, I think we've covered all the bases, but we can talk about that.
I think the list of witnesses that was on
Yeah, we have the list of witnesses.
our website.
I don't know what more you want.
Watch.
We had the coalition.
That's all. Just, maybe giving us the option. If you're not giving us the option, just say we're gonna.
No, I just want to make sure that we're not going to come back and have to go through everything all over again. That's all. So Lauren Lehman, you're here. Do you want to make a comment at this point? I'm happy to hold it over till Tuesday.
No, I was asked to join to answer questions, so if nobody has any questions, I'm good.
Well, the question is whether or not we've done our due diligence in providing information that we need to understand the bill overall. Is there anyone, from your perspective, we will hold over the vote until Tuesday to give folks a chance to look through the witness list. Is there anything else that we should know?
Not from OPR's perspective at this time, no.
Okay, so we'll hold it till Tuesday. First thing we'll do on Tuesday morning. How's that?
Sweet.
But listen, every time we have a bill, we can't just hold it over every time, so maybe I won't give that option next time, we'll see. No, go ahead. Okay, so we are on appointments. That's your job, Sandra.
Yeah, just wanted to highlight that it wasn't marked as a possible vote. So I don't think it was a stretch to,
Let's try it. I'm good. Or- yeah.
stop.
So appointments,
Yeah, so.
I have not called mine yet, so
I've heard back
I'm
from one,
Well,
haven't heard back.
I'm sorry I haven't called.
Okay, so maybe let's just treat this as just a reminder, we all have it's a minor obligation, everyone's got contact info. Let's try again for next Friday.
We can do that.
I mean, I've reached out, I've left voicemails, but I haven't gotten a response either, so I don't have anything constructive to.
I have one that I can present, if you would like. Dr. Tongo, who is on the Board of Medical Practice, she has been on it, wants to continue on it. Has experience as, I think she's a new citizen, she represents multicultural perspective in medicine. And also, offers a surgical perspective on the board, so she's very interested in continuing.
So you're endorsing.
Yes, I'm recommending that we support her nomination to the Board of Medical Practice
Where does she practice?
at UVM Medical Center.
And what kind of, I'm sorry, what kind of doctor?
Surgeon.
Surgeon. And has she served on the board? She serves there now, it's a reappointment.
I can dig her email out. This is coming from memory. I can pull her email out to fill it out if you like.
So I don't quite remember the process from last year, but I know there's a vote involved, but I don't think it's it's not recorded.
No, it's not, but it's recommended from the committee as a whole. And if there are any hesitations, then we need.
So you moved.
Yes.
Need a second, right? I don't know how formal, I just don't remember how.
I can just move
I
it.
think we're supposed to vote on it.
Yeah.
It has to be.
If we need to, I'll second.
Hang on a second. Let me make sure I have that information.
I mean, all of these appointments are Board of Medical Practice, aren't they?
They are.
Yeah, that's what I thought.
There's only 8 total.
Can we,
Last year was at 50.
would it be possible to take 5 or 10 minutes of committee time to make calls? Sort of like in class work instead of homework. Did you sent them all to us, Dave, right?
Right.
Yes, you need
What's her first name?
Margaret.
I could be doing it right now.
Are we still on? Yes, we are.
Okay, so I'll dig it out and have the email, but that's basically for response. Did I move that? I moved that we,
Moved it, seconded it, I don't know if you need a second, but.
okay, all those, just raise your hand if you're free. Good, okay. So we'll send that upstairs. Any opposed? We'll send that, I'll take it upstairs and we'll get it. And this is not underlined, so in case there's a question, we can answer it. I can answer it before. I have not heard back from Dawn Filbert yet. We did have an issue last year with her appointment, but she's on the Board of Medical Practice also. And so I will keep trying her. You good?
Oh, good, thank you.
Okay, so we'll do this, we put it on, you want to do it next Friday?
This one.
Okay. Okay, so we'll just take a 5-7 minute break. Go off live, and then you have 5 minutes.